So I will first start with providing some background on hepatitis C in general and specifically about elimination program. Then, as I said, I will talk about successes, challenges, and science within hepatitis C elimination. To start with the background, since it's not HCV specific meeting, I will provide a few details about hepatitis C in general. Um, Hepatitis C is a viral disease that is endemic all over the world with different prevalence by countries and regions. According to WHO estimates, in 2022, there were 50 million people living with hepatitis C worldwide. And on that same year, there were 1 million people who were newly infected with this virus. World Health Organization adopted a strategy and a goal which targets to eliminate viral hepatitis as public health threat by 2030, and this goal comes with its own targets. However, there is a big challenge in achieving this goal because in absolute majority of cases, hepatitis C is chronic disease with no symptoms. So very often people don't know that they have this chronic infection, and therefore identifying these people and diagnosing them is a big challenge. In 2022, only 36% of people who are estimated to have chronic hepatitis C were actually diagnosed and knew about their infection, and only 20% were treated. Even though the treatment is very effective and can cure patient within several weeks of a treatment regimen, usually 3 months. As for Georgia, Georgia historically was known to have very high prevalence of hepatitis C, and then the highest quality of evidence and the baseline for our efforts was generated in 2015 when Georgia, with the support of the US CDC, conducted the first nationwide hepatitis C seroprevalence survey, which identified that 7.7% of population had hepatitis C antibodies, which means that the person who has hepatitis C antibody has current infection, or it could have been exposed to infection in the past, but not infected currently. And then another follow-up test is to check for hepatitis C RNA, and RNA positivity means that person actually has chronic hepatitis C infection. And the same study found that RNA positivity prevalence was 5.4%. If we extrapolate this percentage on the total population of Georgia, it meant that there are 150,000 people in Georgia who had chronic hepatitis C back in 2015. That survey also identified that the main risk factors driving this high prevalence were injection drug use, history of blood transfusion, mainly from the previous decades when the blood safety was suboptimal, and also there was some mixed evidence, but overall there were some signals that other healthcare procedures such as history of surgery and renal dialysis especially are also contributing factors. By the time this was the highest prevalence of hepatitis C in the countries of Eastern Europe and Central Asia. Further breakdown of the results identified that main affected population were male aged between 30 and 50 years, and this is of course overlapping with the population group which has high prevalence of injection drug use. That same year, Georgia, with support from US CDC, World Health Organization, and with the donation of antiviral medications from the Gilead, this is the pharmaceutical company who developed the first curative treatment for hepatitis C and donated those medication to Georgia for free, and not just one time, but committed to support Georgia in this effort for at least 10 years through 2025. Georgia launched this elimination program. First year was kind of pilot year, and then country developed long-term strategic plan for 5 years, how to eliminate hepatitis C virus in Georgia. And it was important to have a more comprehensive approach and not to focus just on treatment, but also cover other important pieces of controlling the disease, such as promoting advocacy, raise awareness of the population, prevent new HCV cases by preventing transmission, then identify persons infected with HCV, diagnose them through improved laboratory capacity, then provide HCV treatment, and also have a strong surveillance system that would monitor this whole process. This was the world's first formal nationwide hepatitis C elimination program that, as I mentioned, was launched in 2015. We used to say this was first elimination program in the world, but then Egypt often protests because they had treatment program launched before then, even though they never called it elimination program. The program was started earlier than Georgia, but Georgia was the first one to formally announce and declare that our goal is to eliminate hepatitis C. So formally, we were still the first to launch the elimination program. But as a courtesy to our Egyptian colleagues, we added that formal word in this statement. And as I mentioned, just listed, the elimination strategy for that first 5 years encompassed 6 strategic directions. In 2021, Georgia adopted another 5-year strategy. One key change was that this new strategy for viral hepatitis in general and included viral hepatitis B, which is another chronic infection, also very important. And now we are making some first steps in also expanding the program to capture and cover hepatitis B treatment as well for patients who need. Hepatitis B, just as a side note, is more challenging infection because we don't have curative treatment for it, and patients need, once they start treatment, they need to be on lifelong treatment, but it's still life-saving because without treatment, infection causes both hepatitis C and hepatitis B, liver fibrosis, then cirrhosis, often leading to liver cancer, and is often very frequently cause of death in patients with Hep C and Hep B. So as I mentioned, one of the key strategic direction was identifying people with hepatitis C, and this is achieved through widespread screening activities. So screening means initial testing for hepatitis C antibodies, which might or might not mean active infection, but it's the necessary first step because it's cheap and easy test to use. And Georgia incorporated hepatitis C screening. Some screening activities were already ongoing before 2015, such as blood donors. Every blood donation was screened for hepatitis C, and this continued and even expanded to improve the laboratory quality. But then there were some new programs. CDC with its regional laboratories offers free screening voluntarily to anyone who wants to be tested. Pregnant women were also previously tested for Hep C. One new and very big change was that everyone who is hospitalized in Georgia needs to also receive hepatitis C screening. So in legislation, there are some required tests that is done on every hospitalized patients, for example, before the surgery. So hepatitis C was added as a mandatory test for that. And that added another 400,000 or 500,000 people screened every year. Harm reduction beneficiaries, people who inject drugs or people who are on opioid agonist treatment were also covered with this screening. A lot of outpatient facilities offer screening. Prisoners were screened, military recruits, persons living with HIV, or those who were diagnosed with TB. So the program, screening program was very large and is still very large and quite successful, covering, I don't remember exactly the number, but right now 70 to 80% of the Georgian population is screened for hepatitis C at least once. But as I said, this is just the first step in taking care of hepatitis C. And if a person is screened positive, then we start what we call hepatitis C care cascade, which consists of multiple steps. Positive screening test means that either person has active HCV infection, or it means that person had exposure to infection previously, but human body has an ability to clear the infection spontaneously, and this proportion of people who in which this phenomenon is observed ranges, but varies somewhere around between 20 to 40%. Or this means that person was previously cured of hepatitis C, but antibodies are still in the blood. So if a person has active HCV infection or not, we need to identify using another test, which we call HCV viremia, which actually detects virus in blood, and that would be indicative of infection in the current infection on the person. And this usually is done with RNA or core antigen. This is too much lab details, probably not needed for now. If a person is found to be positive for viremia, meaning having current infection, then person can start treatment regardless of disease stage or any other consideration. Anyone who has hepatitis C infection is eligible to receive HCV treatment using this new generation of directly acting antivirals, the drug group that I mentioned previously as a new and highly effective medication. In international literature, you will read that the cure rate for these medication is more than 95%, and that's true for Georgia, and we have even higher cure percentage, which I will show in one of the subsequent slides. Treatment is usually given between 8 to 24 weeks, but the most common regimen is 12 weeks. And whether a person is cured or not is determined using this, what we call sustained virologic response, or SVR. I will use this acronym from now on. SVR is checked 12 weeks after the treatment is over. So once the patient finishes the treatment regimen, then the doctor waits 12 weeks and tests again whether the virus is in blood or not. Because sometimes right after treatment, virus might come back. And with that case, we say that SVR failed. So the cure was not achieved in that patient. And then we need to retreat such patients with like maybe modified regimen. Okay, that was a not very brief background, and let's move to successes. What was done and achieved starting from 2015. One big indicator for success is what's the prevalence in the population overall. And the 2015 survey that I mentioned was repeated again with exactly the same design in 2021. And the prevalence of chronic hepatitis C, which was previously found to be 5.4%, was reduced to 1.8%, which corresponds to 67% reduction in treatment. And unlike 2015, 2021 survey also included children, and survey could not identify any case among children, even though the sample was quite large. So this 67% reduction in treatment means that from 150,000 people, there was only about 50,000 people who were still remaining living with chronic hepatitis C in Georgia. And this is the hepatitis C care cascade, but now with some numbers already. I will not go through all of the numbers. It's probably overwhelming, but just to highlight a few. There were more than 100,000 people who were found to have chronic hepatitis C and were still were eligible for treatment. Eligibility means that they need to be aged 12 or above, and we also check their vital status. So if a person died after diagnosis without receiving treatment, those are excluded from these numbers. More than 83,000 initiated treatment within program. And cure rate among those who were tested for SVR was 99% in Georgia. This varied by different treatment regimens. Earlier regimens in 2015 had relatively lower success rates, but by lower, I mean more than 80% is still good. But overall success rate was 99%. This includes people who had to be retreated and then cured after the second round of treatment. Another way of looking at impact is to do the modeling studies, and we have a very successful collaboration with the Bristol University modeling team, and they did modeling study before at the a few years after launch, and then they recently repeated their modeling estimates and gave some additional information that is not provided by just serosurvey. For example, incidence, or how many new infections occur per year. And this modeling study that showed that incidence of new infections among people who inject drugs decreased by 57%, and overall incidence in the total population decreased by 58%. By March 2022, when this analysis was done, it was estimated that treatments given up to that point averted more than 9,000 cases and saved 842 lives. That's the number of deaths that was averted according to these estimates. And if we calculate and measure how many averted cases and deaths would accumulate up to the 2030, even if the program stopped in 2022, this meant that more than 26,000 cases were averted and more than almost 4,000 deaths. So this modeling shows another strong impact of the elimination program, which is not just numbers, but actual lives saved. Now moving to challenges, my favorite part. Oops, I showed this slide in successes and now I'm showing in the challenges. Can anyone tell me why? That's another way to look at it. Yes, more. What else? Gaps, yes. In previous slide, I tricked you and only emphasized some portions of the slides that were demonstration of challenge, but there are some other portions of this graph that is demonstration of the uh, previous was demonstration of successes, and other parts now will demonstrate the challenges and gaps. First of all, there are these, this is data up until May, I think, because the Zoom window covers, but I think it's May this year. And according to this routine monthly care cascade analysis, we see that there are almost 19,000 people who were positive on the initial screening, are still alive and eligible to receive care. I forgot to mention that care is free of charge for patient completely, like every diagnostic procedure and treatment is free for patient. But still, more than 18,000 people did not follow through the whole process and stopped after screening. There is another important step in the cascade. Even among people who did further diagnostic tests and they were found to have chronic hepatitis C infection, more than 14,000 did not start treatment for hepatitis C, even though they were eligible for treatment and they need treatment. So this is the situation that we have currently. Like we have drugs that can cure these patients and save lives. We have programs, we have laboratory capacity to diagnose them, but there are some barriers, either systematic, either patient-focused or structural, for which we don't reach these patients. Another big blow for this program was, of course, COVID pandemic. And if you look screening rate comparing in the same months in 2019 and 2020, you will see that starting August 2020, when there was big wave started in Georgia of the COVID infections, the screening rate dropped dramatically. And unfortunately, that screening rate did not bounce back after that drop. Even in 2021, 2022, and 2023 remained more or less stable and never went back to the pre-pandemic scale or pre-pandemic numbers. But that's just screening, initial testing. And as I mentioned, we have issues in the next steps of care cascade. And so what we need to do to achieve either finding people who we still don't have identified, or ensuring that everyone who is diagnosed follows through the whole diagnostic procedures and starts treatment. That's already where we need some creative approaches, and that's where I see the big role of implementation science. We know we have treatment, we know we have tools, but we just don't know how to deliver them best. What are the problems? Why don't they receive treatments? And that's a big portion of scientific activities within hepatitis C elimination program. Of course, elimination program also generates some good evidence in terms of like more hardcore science, some biological laboratory, but this more implementation science side and practical side, programmatic side is an important focus of the scientific activities in elimination program. So let's talk science now. Before providing some more details, I wanted to quickly go through how science is managed within hepatitis C elimination program, because I think this is also one of the success model. If beginning the launch of the program, Georgia and the US CDC created scientific committee for hepatitis C elimination program, which was established in 2016 to ensure coordination, communication, dissemination, and transparency of hepatitis C related scientific activities. Members of this committee are representatives of Ministry of Health, NCDC, US CDC, clinicians, researchers, and policymakers, and often non-member participants are invited to these meetings, which are representatives of NGOs, universities, and other partners. Recently, the scientific committee was expanded, and some of the international partners and some members of the NGO were invited and included as a regular members of the committee. Since launch, the program, this committee met more than 50 times and more than 100 projects discussed. At some point, we lost track of exact numbers, so you will see the approximate numbers in some of the statistics I will provide. This is a pathway of how the scientific committee approaches the projects. I will not go through each step in detail, but basically first, whoever is interested party, committee member or outside the committee, submits the concept note of a program. It's reviewed and usually approved at committee, or some feedback is given. And then committee also assists in terms of like obtaining IRB, navigating the research process, ensures that different projects does not overlap, and if they are like very similar projects, recommends the PIs to coordinate and try to harmonize their research activities. And another important component of committee is to actually show the either ongoing or final results. So progress updates are the big part of the committee meetings. There are different sources of data used in the scientific activities related to Hep C. The seroprevalence surveys that I mentioned, Georgia has a nationwide screening registry, which includes information on all people who were screened. And then there is Elimination C program, which is a clinical data set, includes all diagnostic and treatment related data. And there are some other nationwide electronic databases, and there are special studies that specifically request data that they need. During this time, since launch of the program, there have been more than 100 abstracts presented at international conferences, and more than 70 articles related to hepatitis C elimination program directly or indirectly. Sometimes this data is used in the international multi-country analysis and projects were published in peer-reviewed journals in past 10 years. Some of the important recent publications, I will not go into each of them, but this varies widely, starting from blood safety and ensuring high quality laboratory diagnostics to economic analysis and looking at cost-effective ways of managing the program. Now I wanted to focus on one currently ongoing initiative. So as I said, and as I showed that care cascade figure, we have that main challenge now is that there are still some people who were screened positive and they don't receive diagnostic tests, and some know that they were diagnosed but don't start treatment. So one of the activities we are currently working on is to use behavioral and cognitive insights approach. This project is done in collaboration with the World Health Organization and CDC and NCDC. And this project used so-called COM-B framework. COM-B means to have, COM-B has domains of like capability, opportunity, and motivation to assess barriers and facilitators of patient to get engaged into care in three domains, like, and how these different domains affect behavior and behavior change. Behavior change in this case means that person goes to clinic and receives either diagnostic test or treatment. So this project aims to gain insights into drivers and barriers that impacts patients' ability to conduct confirmatory testing or initiate treatment. We also aim to identify opportunities for interventions and policies that will enable, encourage patients to go through this process in care cascade. And this project had one very interesting side product which we worked on together. It's a patient journey in the program. We feel that care cascade that I showed was just a large scale screenshot of what steps patient needs to do. But this project is specifically focused on people who were screened as inpatients when they were hospitalized for some reason and they were screened. And when we had like in-person workshop and then several follow-up discussions and identified all of the steps and all of the things that per person needs to go through. This is what we ended up doing, and this is already. So first version was had smaller boxes, and then we sat down and realized that no, there are some additional things that we added. So these like dark yellow boxes are additional steps or actions that we identified after thinking among ourselves very thoroughly. So this is very complicated, and each box it's can be like implementation science projects on its own. So we are doing very little for now. This is a good starting point, I think, what we are doing with WHO BCI work, but there is still a lot to do. And there are several other ongoing projects, either directly fitting in implementation science or not very directly, but I picked up some of them. There is a project that routinely tries to enhance linkage to care for patients who are lost to follow-up. This is a more programmatic approach where NCDC contacts the patients who did not follow through the cascade by phone and sends them a reminders and tells them that reminder that you were screened positive and you need to do the following steps. There was a project that tried to assess if how would be the uptake of self testing in the general population. So there are some new tests available that can be done with saliva, and person can do it on its own at home. This data collection is done, and manuscript is currently drafted. There are a lot of activities focused in people who inject drugs, such as some aim to try and evaluate peer-to-peer recruitment. Another activity assesses the incentivized peer interventions. We have some examples of collateral benefit of hepatitis C elimination program on some other diseases and other areas. So one of the previous screenshots I showed was an article which demonstrated how blood safety, how much blood safety improved since the launch of the hepatitis C program, and not only for the hepatitis C testing, but all transfusion transmissible infections. And another example is to use this knowledge from Hep C and uh, try to improve the care for tuberculosis, for example. There is this pharmacokinetic study that tests the what is the tolerance, and if we can do the parallel treatment for tuberculosis and MDR tuberculosis and hepatitis C, led by my colleague who is now in the um, audience, Mari, and we're looking forward to these findings because it would be a very unique study looking at the pharmacokinetics of parallel treatment. There is another project looking at integrated HCV, HIV, and TB screening program. So in primary healthcare, these three infections are screened at the same time. So now we are trying to assess what's the what does care cascade look like specifically in those people who were screened in primary healthcare. And I added this box for etc. because this is just a very small portion of those 100+ projects that have gone through the scientific committee. I always struggle to write an acknowledgement slides for this kind of presentations there because there are so many people involved. So I decided to provide names only 3 persons who directly contributed to this presentation and sent me some data or slides, my colleagues from CDC Division of Viral Hepatitis. But beyond that, there are a lot of clinicians, policymakers, public health specialists, and many more specialists involved in the implementation of hepatitis C elimination. That was all. Thank you, and happy to take any questions.
Thank you, David. Thank you so much. We have time for questions, comments. Yes, please, Nino.
First of all, thank you very much for this excellent presentation. I really enjoyed to listen this success and challenges as you demonstrated.
Okay.
So,
can I ask everyone who would pose question to briefly introduce ourselves? Thank you.
Nino Mirsekashvili, Associate Professor, Ilia State University. So my question is about, I still believe that this is one of the successful program, by the way, of the current political party and the Georgian government. But still, when we talk about the challenges and the success, how do you think, and your opinion is very important. Do you think that we achieved, and this is successful program because prevalence is still 1.8 and the target was elimination and target was 0.5 prevalence, I remember. And also you're talking about the screening rate, how it has dropped, and also the people who are screened positively and have the hepatitis C and they are not included in the state program. So there are lots of challenges currently, as you mentioned. And how do you think that can this program be successful in the future if we don't change or remodify or redesign the program? Otherwise, we cannot achieve the elimination of the hepatitis C as it was targeted in the beginning of the program. How do you think? And role of the implementation science in this regard.
Yes, I think it is clear that we need to change something, and it's we are keep saying that we are in the last mile, and the last mile is the most challenging, and we've been in this last mile for almost 5 years now, and we see the same struggle in that 2 steps of care cascade, and there are other indicators for elimination, for example, incidence of new infection, which is target is 5, but Georgia currently is at 66. So we are definitely still far from the elimination target, and you're absolutely right that we need to change something. I don't know whether it should be like necessarily modification of the program or adjusting it. I definitely see the role of implementation science and this BCI work using implementation science framework is a very good example. We realize and we acknowledge that even though there were a lot of smaller activities that aimed to improve linkage to care, they were not comprehensive enough. And there were only anecdotal data why these people do not actually go and receive treatment when there is this free treatment available. And it's not always on the patients. We found that a lot of people don't even know that they were screened and they were positive. There is a big systemic problem of not having all the pieces together. It's just treatment, but not adequate counseling of these patients in the hospital sector or other sector. There is still a lot of information campaign required because even like yesterday we had guests to the CDC office from the US Embassy, and we had like general presentation about our work, and we also mentioned hepatitis C elimination program, and one of the guests said, "This program is over, right?" And it was like, "No, it's not over. It's still going." And that's the case in the general population also. A lot of people forgot that this program is still going because the information campaign really dwindled and are not as active as they were at the launch of the program. So this is a very complex program and has a lot of pieces, and it definitely needs another push, another driver that will accelerate the process and address some of the gaps. One positive development that we hope will help the Hep C elimination process is inclusion of Hep B in the program. And one hope is that because this is new, and we hope that this will have the same effect as it had the launch of Hep C. When everyone was talking about, there were a lot of patients waiting to be treated. So we hope there will be some collateral benefit of Hep B program to Hep C, but of course that won't be enough, and we need to do more.
Thanks a lot. However, about the hepatitis B, this new program also, there is lack of information campaign because I believe that even in this room, not many people know that this new program was launched recently, and from September it will be for free. This program and financed by the state. So still, I mean, I do not agree that it will help.
Yeah, at this point, you are absolutely right. It's not advertised too much, mainly partly because it's not ready fully to be implemented. They are still working on the database. Drug procurement is in the process. Well, let's hope that the situation will change.
Thank you. Any other questions from the room? Yes, please.
Hi, Shulpan Primbetova, Kazakhstan. What about who is covering the payment for HCV in Georgia? Is it on the government budget or donors? And who are eligible? Is it only citizens or like migrants or residents of Georgia are eligible too? Thank you.
So in terms of financing, the medication is still donated, and the rest is covered by the state program. So it's publicly funded from the state budget. As for eligibility, it's just residents of the country. Yeah, I'm not sure about the citizens. Yes. As I know, migrants, for example, and non-citizen residents are eligible for screening. For example, like if they get into antenatal care or hospital, they would be screened also for free, but not the rest of the care cascade steps, diagnostics and treatment.
Thank you.
Any other questions?
No. Yes, there is.
Hello, Nina Baliashvili, doctorant of Ilyas State University. Do you know or do you have any information about practice in Egypt because they have similar program and what's happening there and what type of results do they have?
Sorry, could you repeat?
Egypt,
Ah,
because as I know they have a similar program and can we use their practice or something like this?
uh, um, I have to admit that Egypt is slightly ahead right now because so in addition to final elimination target, WHO also has an intermediate path to elimination validation, acknowledging the successes on the way to elimination. And so far, Egypt is the first and only country, I think only, colleagues can correct me if I'm wrong, the only country who was validated as on the path to elimination. Georgia is right now in the process of compiling all the required documentation to apply for the validation of path to elimination. So we are still very close, but in the last few years, Egypt rushed ahead of us. And we've worked well together. I remember I was working at the CDC Georgia when the program was launched, and in 2014, 2015, there were a lot of communication with Egyptian colleagues. Their treatment program, not such a wide scale, but their treatment program was already started at that time. And there was a lot of information and experience sharing from their side. Georgian clinicians, as I remember, I hope I'm not making this up, but I think there was even delegation from Georgia who visited Egypt and saw their experience. So there has been this collaboration. In terms of programmatic, yes, they are doing a lot of things that we follow. For example, the incidence estimation is a big challenge, and it requires some special studies. And Egypt has done some interesting studies when they piloted the program where they went door to door in like several villages, tens of villages, and did very active screening diagnostics and provided treatment right there in the field. And then they followed this cohort and estimated the incidence. So there are some interesting differences between countries that are monitored from both sides, I'm sure, and then if applicable, also replicated in other.
Thank you.
Thanks.
Yeah, probably the last question.
Hello. First of all, thank you for this interesting presentation. I'm Lasha Chantadze. I'm a clinical psychologist, and my question is about your main challenge. You already emphasized that already about 20,000 people should start treatment, but they don't start. So I wonder, have you done any study or research, like what is the main reason these people don't start treatment? Like maybe it's the social factor, maybe it's a knowledge problem or something like that. So do you have any information which is the main problem for this, that they don't start treatment? Thank you.
We don't know which one is main. One study that I mentioned with WHO using COMBI framework will give us more insight because it includes some, it's mainly qualitative study trying to go really deep and ask patients about their journey and what were the main barriers. From quantitative studies done up until now with these phone calls, we have several factors that is commonly named. Big issue is that some don't know that they were actually tested and they need treatment. Another big issue is that just by nature, most of the cases are asymptomatic. People don't feel any symptoms, and just some people just don't like taking medication and healthcare. And we can assume that this is lack of information about how serious the infection is, that even if you don't have symptoms, you still need treatment. There are still, unfortunately, some leftover myths about the medication, that it's not well tested, that it is still experimental, and some people don't trust medication, even though it's used worldwide and it's very safe. Like side effects is extremely rare. So those are some of the factors that are commonly found in that people.